The imaging techniques utilized in magnetic resonance mammography are obviously to some degree unique both to the vendor of the MRI machine used as well as to the capability of your individual MRI platform. In this section, I would like to provide some general imaging concepts which I feel should be utilized regardless of the vendor or individual MRI platform you use. For specific protocols, please refer to the following section where protocols are listed by vendor. The foundation of any breast MRI protocol is the post-contrast dynamic acquisition series. We feel very strongly that this acquisition must include bilateral and simultaneous imaging of the breasts. We have found that this can be accomplished regardless of the level of sophistication of your MRI system. We have utilized a single pre-contrast acquisition followed by 5 post-contrast series. The first post-contrast series is the most diagnostically useful. However, the remaining 4 post-contrast acquisitions are utilized to generate kinetic curves. This acquisition should be performed with a slice thickness of 4 millimeters or less with no interspace gap. Ideally, a slice thickness of 3 millimeters or less is preferred, whether scanned or interpolated, and will obviously depend on your scanner capabilities. We designed the individual parameters of this dynamic acquisition to conform to time limitations of approximately 60 seconds to a maximum of 80 seconds per dynamic acquisition. We feel this is necessary in order to image the parenchyma rapidly enough to identify the early peak enhancement of malignancy, preferably from the background parenchymal enhancement. This dynamic acquisition optimally should be obtained with fat saturation techniques. However, in the absence of this capability, subtraction imaging is sufficient provided your technologists are able to adequately position the patients to reduce any motion artifact. We find it useful to utilize both fat saturation and subtraction techniques. A stir acquisition, generally performed in the axial plane simultaneously of the breasts, has proven to be a very useful pulse sequence in our practice. This is generally not performed at particularly high resolution, often at approximately 4 millimeter slice thickness. In this scan, we are not looking for detailed anatomy, but rather a very reliable and very sensitive pulse sequence for edema or T2 signal. This is useful for a quick overview of cystic changes in the breast. It is also very useful in detecting asymmetric parenchymal or skin edema, which is always pathologic and warrants further evaluation. We have additionally found the stir sequence to be of use in evaluating areas of non-mass-like enhancement, particularly when trying to differentiate fibrocystic change from in situ carcinoma. You will see examples of this in the teaching file section of this training tool. The final imaging sequences are utilized primarily for high-resolution evaluation of the parenchyma. Initially, in our practice, we performed high-resolution fast-spin echo T2 weighted images. We tried to always perform the high-resolution acquisitions in orthogonal planes. We find this especially useful in evaluating lymph node morphology, whether in the axilla or, more importantly, identifying intramammary lymph nodes, which can demonstrate concerning enhancement kinetics and potentially be mistaken for malignancy if their characteristic morphology is not recognized. We did encounter an isolated incidence of a mucinous cancer, which on T2-weighted imaging appeared to demonstrate a classic reniform configuration with a central hyperintense hilum of what we assumed was fat. In reality, this appears to have been related to mucin or other T2 hyperintense material centrally within the tumor. Immediately following this case, we subsequently began orthogonal high-resolution imaging with fast-spin echo T1-weighted, non-fat saturated pulse sequences. We do still utilize one sequence of T2-weighted imaging, either with or without fat saturation. In a 1999 article by Kuehl, the T2 signal characteristics were suggested to be of benefit in differential diagnosis with an elevated T2 signal correlating with benign disease. A 2006 AJR article by Bartella et al., however, noted that tumors could demonstrate hyperintense T2 signal in 24% of cases in their study. An additional 12% of malignancies demonstrated intermediate T2 signal. These latter findings are more in line with the findings we have noted in our practice. We do not allow hyperintense T2 signal to necessarily dissuade us from a diagnosis of malignancy if the morphology or enhancement characteristics are suggestive of cancer. Having said this, we do generally still obtain a fast-band echo T2 acquisition in our pulse sequences, as occasionally this can be an additional piece of evidence to suggest benign or malignant disease. In the next section, you can find specific imaging protocols for various vendors. We have entered protocols that we utilize in our platforms. We have solicited from individual vendors their protocols. At the initial release of this training tool, not all vendors have submitted protocols.